Vigilant monitoring is key to critical care and patient safety. ICU bedside providers must have a good understanding of how monitors work in order to interpret the data and make sound clinical decisions. Oxygenation, ventilation, circulation, and temperature are the key parameters that must be monitored during intensive care. Pulse oximeters have two components, a probe and a computerized unit. The probe is placed on the patient's finger or toe. In small infants, the probe may cover the entire hand or foot. The probe has an LED light and photodetector. The light is shown through the patient's tissues. Oxygenated and deoxygenated hemoglobin absorb the light at different wavelengths. Oxyhemoglobin at 940 nanometers and deoxyhemoglobin at 660 nanometers. The ratio of wavelength absorbed is converted to a percentage and displayed on the pulse oximeter, and this is referred to as the SpO2. Normal SpO2 is greater than 94%. Since it is the arterial oxygen saturation that is of interest, the pulse oximeter discounts any non-pulsatile flow, such as that from venous blood, capillaries, and tissues. Pulse oximetry requires a regular pulse for proper data collection and accurate readings of the SpO2. Disruption of a regular pulse detection can lead to erroneous SpO2 recordings. Examples include vasoconstriction from hypothermia, vasoactive medications, or hypotension. Dysrhythmias such as atrial fibrillation, ventricular tachycardia, or other abnormal cardiac rhythms. Shivering and electrocautery can also interfere with accurate SpO2 readings. Disruption of the wavelength absorption ratio can also lead to false SpO2 recordings. For example, injectable dyes lead to falsely low values, whereas carbon monoxide poisoning can lead to falsely elevated SpO2 values. Electrocardiograms are standard monitors for ICU patients. Using a 3-electrode setup allows monitoring of leads 1, 2, and 3, but only one lead can be examined at a time, while the third electrode serves as a ground. Lead 2 is best for detecting P waves and sinus rhythm. Using a 5-electrode setup with 4 limb leads, right arm, right leg, left leg, plus V5, which is placed in the left anterior axillary line at the 5th intercostal space. V5 is 75% sensitive for detecting ischemic events. Lead 2 plus V5 is 80% sensitive. And lead 2 plus V4 plus V5 together is 98% sensitive for detecting ischemic events. Most automated blood pressure cuffs use a technique called oscillometry, where cuff inflation leads to occlusion of blood flow. Slow release of cuff pressure allows resumption of blood flow, and oscillations associated with turbulent resumption of flow are recorded. The point of maximal oscillation amplitude corresponds to mean arterial pressure. With oscillometry, the systolic and diastolic blood pressures are derived from algorithms. If the blood pressure cuff is too small, the blood pressure will be falsely high. If the cuff is too large, the blood pressure will be falsely low. Arterial lines are invasive and can be painful for patients during placement. Indications for placing an arterial line include close monitoring of blood pressure, for example when using vasopressor or inotrope medications, and repeated blood sampling, such as arterial blood gas samples. Complications include pain, bleeding, hematoma, infection, thrombosis, and ischemia. Arterial lines are placed most commonly in the radial artery, but can also be placed in the femoral, brachial, or dorsalis pedis arteries. Sterile technique should be used during placement. Arterial line monitor systolic and diastolic blood pressure directly by detecting the pulse beat against a fluid-filled pressure tubing, which is connected to a transducer. The transducer converts the pressure sensed into systolic and diastolic values, which are displayed on a monitor. The arterial line setup system must be zeroed, which exposes the system to atmospheric pressure and establishes atmospheric pressure as 0. When the system is again closed to the atmosphere, any pressure encountered is arterial blood pressure. Since water columns can also exert pressure when affected by gravity, the transducer is typically kept level with the body area of interest. For blood pressure, this is usually at the level of the heart. Capnography is the measure of exhaled carbon dioxide. Capnography is displayed as a waveform on the monitor with each phase of the wave corresponding to each phase of the respiratory cycle or breath. The beginning of exhalation is dead space. This is followed by the transition between airways and alveolar gas. As the waveform levels off, it corresponds to the alveolar plateau or end-tidal carbon dioxide. Finally, as inspiration starts again, the waveform should reverse flow and drop to 0. Temperature is routinely monitored in the intensive care unit. Multiple sites, including the pulmonary artery, tympanic membrane, esophagus, nasopharyngeal, rectal, bladder, axillary, skin, and oropharynx can be used. Pulmonary artery, esophageal, and bladder approximate core temperature.